For those of you who are on and listening to us chat and catch up, thank you for signing in tonight. And for those who are joining via recording or will be joining in a few minutes, also welcome. It's my great pleasure to introduce my colleague, Carrie Dougherty. Dr. Dougherty is an associate professor of neurology at MedStar Georgetown University Hospital and the program director for the fellowship program for the MedStar Georgetown Headache Medicine Fellowship. She's board certified in neurology and headache medicine, and she's an excellent migraine neurologist here to help demystify migraines, answer questions, and hopefully we'll all have a good time talking about headaches, if you can have a good time talking about headaches. So we will go ahead and let her begin her presentation. If you have questions, you can put them in the chat or in the question and answer box. I think we'll hold most of those until you finish up with your presentation, and then we'll open it up for questions, and I will moderate. Oftentimes we'll have kind of multiple questions on the same topic, so I'll try to hybridize those where I can, and hopefully everybody will learn a little something tonight. So with that, I will go ahead and kick it off, and thank you so much to Dr. Dougherty for joining us tonight.
Yes, thank you for having me. I always love to come and talk about migraine, especially so Dr. Cilenti and I went to medical school. And so once on the elevator, me getting off and her getting on, I was like, I know you. Being a Midwesterner in DC, nothing makes you more proud to be a Hoosier than when you see someone else that knows where you're from. But yeah, there's no shortage of puns about headache or needles in my life. So we will give it a shot and try and talk about migraine. So I do have some disclosures. We do research and consulting work for some of the manufacturers of some of the medications that we use in migraine, as well as some of the devices. My favorite quote when talking about migraine and understanding what everyone else's experience is like is actually from Joan Didion, who has an essay that if you experience migraine, I would encourage you to Google. You can kind of come up with the entire essay without a paywall, remarkably. She had migraine all her life and had a lot of experiences with physicians where she was not taken seriously. And she gives just a really good account that I think she wrote this essay probably in the 1970s. But if you read it now, it is sad how similar it is to the experience of many of the patients that I see in clinic. But she talks here and she says, I had no brain tumor, no eye strain, no high blood pressure, nothing wrong with me at all. I simply had migraine headaches, and migraine headaches were, as everyone who did not have them knew, imaginary. So I think it really speaks to the experience of lots of individuals who experience migraine and feel like they are the only ones, and that when you're trying to explain what it is to have migraine and what a whole body process it is to someone who doesn't understand, how frustrating it is and how you can just really feel not heard. And so one of the things that I really like about my job is that I feel like it just involves listening to individuals tell about their experience, and that it's actually a fairly easy diagnosis to make if you listen to what people have to tell you about what they experience. So migraine stigma, which is what Joan Didion's article kind of alludes to, is really pervasive and is actually really high, even amongst other neurologic disorders. The stigma that exists for patients with migraine is actually reportedly in one study higher than patients who have epilepsy or seizure disorder. And a couple of facts from a recent study of patients with and without migraine about what they thought about one another was that around 30% of people who don't have migraine often or very often thought that people with migraine either used it to avoid commitments, exaggerated their symptoms, or that those individuals experienced migraine as a result of their own unhealthy behaviors. And then around 30% of people who experience migraine often or very often reported that they felt that others believed that they were using migraine for an unfair advantage or secondary gain, and that they would have to minimize their experience in talking with others about having migraine. And I see this a lot in clinic, where individuals just stop talking about it to friends and family and coworkers for the fear that they will be judged as being unreliable, um, as being, kind of flaky. You can't make a commitment. You have to cancel because you have migraine. Isn't there something you can do about it? Shouldn't you see a physician? Aren't you taking medication? And people want to, loved ones often want to help and will offer all manner of um, advice on what you could do to reduce migraine. Lots of stuff found on the internet. And it's often well intentioned, but just can feel really burdensome to the person who experiences migraine. And I think kind of talking about it and certainly having a forum here where we talk about it and kind of explain the neurologic illness that is migraine and all of the symptoms it encompasses gives more voice. So I hope it's helpful for you. One of the ways we talk about how migraine affects everyone is just asking them, how does migraine affect your everyday experience? How does migraine affect what you want to do? And we find that it affects work, where patients will have to call out. And that can be, a source of problematic both to their employer and their coworker. Also, that they have to cancel plans with friends, or sometimes that they have to cancel so many plans that they stop making them. I think that's always kind of the saddest part, is when someone stops making plans because of migraine. And then living and parenting with migraine is that, oftentimes children can just look at you and say, oh, I know mom has a migraine again. They can just see it on your face and they can be disappointed, and that can feel really heart-wrenching. So in summary, we know that migraine is real. It's not just a headache. It involves neurologic, sensory, autonomic, vestibular, so dizziness, cognitive, and GI symptoms. And it's a chronic neurologic disease that's involved with disordered sensory processing. So we often talk about patients who have migraine are hypersensitive to kind of any kind of changes in their environment. And that heightened awareness makes them really sensitive to kind of this process starting. It's largely genetic. So if you want to know how to avoid migraine, it's to choose your parents. So unfortunately, a lot of these things are outside of our control. But then we know that changes in the environment can kind of lower the threshold. And this is where the concept of migraine triggers plays in, is that a lot of things that can fluctuate on a day-to-day basis seem to contribute or lower the threshold for you experiencing migraine. It's very common. So 47 million Americans. It affects 1 in 5 women and 1 in 10 men. And it's the second leading cause of disability overall, but the first among women between the ages of 15 and 49. So really at the height of when you're starting your life, working, starting a family, just getting going, is when migraine oftentimes is the first chronic illness that someone has to deal with that causes disability. So the diagnosis of migraine has very elaborate and long criteria, but a lot of physicians who found that to be kind of challenging and onerous distilled it down to just 3 questions. And so if you're wondering, or you signed up for this webinar thinking, I have headaches, I don't know if they're migraine, the things that we ask are, has headache limited your activities for a day or more in the last 3 months? So if you stop what you're doing because of head pain, chances are you're experiencing migraine. Also, if you have any sort of nausea or upset stomach around the time of the head pain, or if you feel like you'd feel better if you turned off the lights or dimmed them, that's also a feature of migraine. As I'm sitting here with my ring light, making myself look good to talk to y'all. There are certainly other types of headache that we diagnose in a headache clinic. Tension type headache is probably the most common amongst everyone in the universe in terms of the experience. But typically it's very infrequent. We call it episodic tension type headache. And it's oftentimes a band-like pain that you have and doesn't really ever progress to be severe, doesn't make you stop what you're doing, isn't associated with sensitivity to light or sound or noise. And oftentimes, unlike migraine, if you exercise or get up and distract yourself, it will dissipate and go away. Sometimes if I'm on the fence, because tension type headache is bilateral, and oftentimes we think of, or both sides, oftentimes we think of migraine as being one-sided, although not always. And there are lots of patients who have migraine that's on both sides of the head. But if I'm on the fence and I'm not quite sure, and I ask you, if it was a day that you were scheduled to work out and you had this type of headache, would you cancel or go? If you'd cancel because you think that it would just be miserable to try to do yoga or running or anything that involved physical exertion, and that you know it would make your head pain worse, that's clearly a feature of migraine. Whereas with tension type headache, oftentimes cardiovascular exercise in the moment will make you feel better and can be therapeutic. The other headache that oftentimes is discussed is cluster headache. And we can use the word cluster to describe a lot of like the way migraine occurs, where migraine may cluster around your menstrual cycle. Migraine may cluster where you feel like you have them back to back to back several days in a row and then they dissipate. But cluster headache is a different type of headache. It's oftentimes actually experienced by older men. It is always one-sided and it's very short, oftentimes between 15 and 45 minutes. And a migraine, an untreated migraine oftentimes lasts more than 2 hours, sometimes up to 3 days, and sometimes, unfortunately, even longer than that. And with a cluster headache, you have a lot of eye watering and nose running, and patients are agitated where the pain is so severe that they will rock back and forth. And certainly the pain of migraine can be exquisitely severe, but patients still have a preference typically to lay down or rest, although not always. I joke that your bodies never read my textbooks, so sometimes it fits and sometimes it doesn't. When we talk about migraine in terms of head pain and light sensitivity, what we're really talking about is the headache phase of migraine. And one of the things that I think is helpful for patients to understand is that your brain is constantly affected by migraine, and you are in and out of certain phases of migraine fairly commonly throughout like a day-to-day period. And the things that we don't recognize is up to 3 days prior to having a migraine attack, you can have what's called prodrome, or the premonitory phase. And in that phase, you can have problems concentrating, you can have neck stiffness, you can have increased sensitivity where you feel like lights are a little bit irritating, or noises are a little bit more irritating. You can also have food cravings where you feel like you want to eat certain foods, and you can increase the frequency with which you go to the bathroom, you urinate. And so when we think about triggers and we look back at like a migraine calendar and say, what caused my migraine? What I oftentimes am explaining to patients is that even before the head pain is starting, your brain is affected by migraine. So if you look at a diary and say, well, the day before I had this migraine attack, I, ate chocolate, or I was really irritable, or I was out in the sun all day at the beach. The sun was really irritating. It may be that you were in a sensitive state because this migraine had already started. And so we're just learning the beginnings of understanding this premonitory phase. We think it has to do with the hypothalamus, which is the part of your brain that regulates a sleep-wake cycle, and all of the things involved in homeostasis, which is why I preach the migraine brain does not like change. It likes everything to be the same every day, that you wake up and go to bed at the same time, that you have even keel stress, that the weather never changes. Very robotic existence kind of behooves someone who has migraine. But we can't live our lives like that. Things change, and a lot of those things are outside of our control. But understanding premonitory symptoms oftentimes gives you insight into when the migraine may follow. Now, the next phase that I show you here on my graph is aura, and only about 25 to 30% of patients experience migraine aura. And we think of that as neurologic symptoms that can accompany migraine. Most commonly, they're visual, and oftentimes it starts with a zigzag line or shimmery, like bright spots, almost like fireflies. Fancy word for them is photopsias. It's always fun if you're not sure. If you Google migraine aura, more creative people than I have come up with really great representations of what it looks like. To have like the spot in the visual field that looks like you looked at the sun and then you look away where you have a bright spot that kind of obstructs your vision. That typically starts off small and then increases in your visual field over the period of usually around 15 to 20 minutes, but can be as long as an hour. And in some individuals, in addition to visual symptoms of aura, it can involve numbness around their face or their hand, and rarely even weakness. It can also involve speech changes. And we think this process of aura happens inside the brain, whereas the nerves that give you the pain of migraine get activated outside the brain. And we call this process cortical spreading depression. And it just means that these nerves fire and then they spread almost like the wave at a concert across the cortex of your brain and give rise to these kind of evolving symptomatologies. So patients who have aura oftentimes don't recognize that the other bad headaches that they get are also migraine because aura is so distinct and unique. But most patients are prone to actually experiencing both. And then the headache phase, we all know and love. That unfortunately we're too familiar with. In addition to what I talked about, the light and sound sensitivity, motion can be bothersome. You can feel like you don't want to eat, even if you're not actually nauseous or throw up. You can feel super tired, trouble speaking. You can be dizzy, feeling like you can't think straight. And oftentimes you have a lot of other GI symptoms. So that typically lasts, like it says here, between 4 and 72 hours. And then afterwards, you have what I like to call the migraine hangover, in which someone's actually written out here. Not our technical term. We like to call it postdrome when we write it out and sound academic. But that's when you're wiped the day after. You feel like you have kind of a lingering fog, still with pain, need to kind of sleep, aren't really thinking straight. And that's the whole process. So as you can see, even if the head pain only lasts for 4 hours, it starts days and ends days later. So it's no surprise why it's so disabling. So I write here, because this is one of my common questions. Oftentimes patients who have migraine as a part of their prodrome will have a lot of neck stiffness and neck pain. And that pain can radiate from the back of the head forward and feel like the neck is the source of the migraine. And a lot of patients who have, persistent neck pain and migraine will ask, sorry, I had to drink water. Is the migraine caused by my neck? If we get an MRI, we see a lot of us have arthritis in our cervical spine. And certainly you can find an excuse for one of those calcium depositions or disc bulges to potentially irritate the nerves. But oftentimes we think that actually the migraine is the cause of the neck pain. And so I show here the nerves that do sensation to the face are the trigeminal nerves. And they're trigeminal, but they have 3 branches. And we characterize them by Roman numeral 5. So we have V1, V2, V3, the 5 branches, or the 3 branches of the 5th cranial nerve. And they all synapse in the same place as the upper cervical spine nerves synapse as well. So C1, C2, and C3. And C2 and C3 give rise to the greater occipital nerve, which is what does sensation to the back of your head. And so in some patients, instead of the migraine pain settling behind the eye, it may start in the back of the head at the greater occipital nerve and radiate up. But it's just, that whole system is irritated, and whether or not your migraine starts in the back or the front, the treatment and the interventions are oftentimes the same. I like to talk to patients a lot about triggers because a lot of us are looking for ways to decrease the frequency of migraine and kind of exert some control over what happens to us. Unfortunately, like when you're really trying to reduce your frequency and pay attention to all your environmental triggers, you can sometimes increase the amount of disability that you have because of migraine because you're constantly avoiding things that could potentially give you migraine. I also feel like if you're super concerned about something in your world giving you migraine, and then your migraine occurs, you may think, I caused this to happen to myself. Chocolate is a trigger for migraine, and I had a chocolate bar in a moment of weakness, and now this is my fault. There's actually not much evidence that any one exposure will result in a migraine attack for a large population of patients. So meaning if I put everyone on a migraine diet that eliminates tyramines, for example, which is one that's gotten some discussion and oftentimes gets talked about, there's no evidence that says it reduces the frequency or severity of migraine for the next 50 people that I do it for. Now, there may be one individual for whom it makes a difference, but for the next person, not at all. And so most triggers kind of declare themselves over time, where a patient will come in and tell me a story and say, yeah, red wine does it for me. So you know what they do? Pull out red wine, drink white wine, don't drink at all. and learn to kind of modify their triggers. It's unlikely that you have a big trigger in your life that you are unaware of. They will make themselves evident. So don't spend a lot of time avoiding triggers. Live your life, because if you're constantly living in fear, then you may never have migraine, but you won't be doing, the things that you enjoy. What if you're experiencing migraine or really severe headache, you may be worried that it's not a migraine. What if it's something that's dangerous? If you're having recurrent headaches that you've had for years that feel the same and kind of follow the same pattern and haven't really progressed in frequency to being daily, in general, an MRI doesn't give us very much information about what's causing your head pain. It really is overactive nerves that you are genetically predisposed to. And if we go and take a picture of your brain, we may see changes in your brain related to migraine, but they're not the cause. Sometimes if you have migraine and you've gotten an MRI, you'll get a report back that says non-specific T2 hyperintensities that can be seen. And if the radiologist is generous, he'll give you a really long differential that includes scary things like multiple sclerosis or Lyme disease or vasculitis or hypertension and or migraine. And the chances are the non-specific, it is and or migraine as the explanation. There are changes in blood vessels that occur with migraine, and we see the evidence of this on the MRI. We have looked at them over time. There's one study that followed patients who had these changes and then followed up with them again a decade later. And they were not associated with any increased risk of other neurologic disease or of dementia or any kind of cognitive decline. It's just kind of a phenomena that happens in migraine. So my asterisk is, we do seek imaging in someone who has, if you have an aura for the first time, meaning you have numbness or tingling or trouble speaking, and that's never been a symptom of your headaches, that would be a reason for us to look. If you have new symptoms, like all of a sudden I have, horrific vomiting and that's never been a part, we might look again. If your headaches are getting worse and they've progressed to daily, maybe time to take a picture. If it's what we call a thunderclap headache, so thunderclap headache to all physicians is generally an emergency and a reason to go to the ER. So if you are fine 1 minute and you have a 10 out of 10 headache that kind of hits you like a clap of thunder and escalates from a 0 to a 10 in less than a couple seconds, that's a reason to go to the ER. Do not pass go, do not collect $200. It's time to go get that checked out. And then of course, when we see you in clinic, if there's something abnormal on your exam, you have unusual reflexes, you have changes in your eyes, all of those are reasons why we would get a picture or find some explanation for why that could occur. So if you have migraine, what can you do about it? So I've already told you I have a small soapbox about avoiding elimination diets, just because in general, I find that they make people miserable and they still experience migraine. If you do really want to make a change, the one caffeine does have evidence to be what I call a double-edged sword. So everything that you find over the counter that's labeled as an acute treatment for migraine has caffeine in it. And the reason is because caffeine increases how quickly a medication will work. It speeds on the onset, and that's what makes the over-the-counter meds a little bit more effective. But if you have too much, it can sensitize the system and make those nerves more likely to fire. And so having caffeine at high frequency or using a lot of caffeine containing medications can actually increase migraine frequency. So sometimes that is something that you have within your control. Now, I did say that if you have a migraine, you're not going to want to exercise. But in between migraine attacks, cardiovascular exercise is preventive, and it can be, low impact. Oftentimes, like in the summer, if you're trying to go for a run, that can actually be a trigger for a migraine, where it gets back at the idea that migraine brains don't like change. So you walk out the door because you're a working mom and you only have a half an hour and you're going to kind of make the best of it. And you don't do warm up and you didn't really drink anything extra. And then you just go run hard. Your heart rate, your blood pressure, your body temperature all have changed very rapidly from your indoor air conditioned environment where you were resting to full on exertion while you're running. And that change can lower your threshold and result in migraine. So the key to working out with migraine is lots of warm up and lots of cool down and all of the exercises that are unfortunately boring. So you want to do them in a controlled environment, which means running outside is probably not ideal. It's the elliptical, it's swimming, it's doing a stationary bike in, an air-conditioned environment where you can kind of control those variables going up and down. And then over time, you may be able to increase the level of exertion and go for a run outside as it gets a little bit cooler as we move into the fall. But those are really the ways to exercise if you have migraine. Obesity is an associated risk factor for increasing migraine frequency. So weight loss can behoove you in terms of migraine. And then regular sleep. So disruptions, like I said, circadian rhythm, all of those can lower your threshold for migraine. So you want to make sure that you're getting up and going to bed at the same time. If you're someone who sleeps in or stays up late on the weekends, oftentimes you'll notice if you sleep in, actually, it doesn't help you, and you may be more likely to experience migraine. And if you're not sleeping well and you have a lot of disrupted sleep, that can be something that needs to be addressed to help your migraine. So when we talk about treating migraine, there are two ways that we intervene for migraine. One is acute treatment. So that's, I have a migraine headache. I want to feel better now. What do I take? And the most, clear examples of that are something that's over the counter, like Excedrin or Motrin, or prescription kind of acute medication like sumatriptan. The other type of medication that we use is preventive, and that's something that is taken with some regularity. So they used to all be daily pills. Now we have long-acting injections that last for a month, and then we have onabotulinum toxin, which is Botox, which is every 12 weeks, but essentially is in your system. And those are resetting the threshold for nerves to fire, making them less likely to fire so that your migraine frequency is reduced and the attacks themselves are less severe. And this is something that's really underutilized. We think about 40% of patients and anyone who has chronic migraine, and chronic migraines is defined not by how long you've had it, but by how many headache days you have. So 15 days a month or more, and 8 of those days you think are migraine or you use a migraine specific medication to treat, that's chronic migraine. But really the threshold for starting preventive to reduce frequency is around 4 days a month, because we think that if we don't intervene, potentially your frequency can go up. So what are our acute medications and how do we use them? Well, you've likely been told the best efficacy for any intervention is early. The longer you wait, the less effective it will be. I like to think of the nerves that fire during migraine. If you think about like a big cable of neurons, and some of them are initially firing and some of them are not, the medications either stop more from firing or they mop up the inflammation and the signaling pathways. And so if you can intervene when just a couple of them have fired, you will do better than when the cat's out of the bag and they all have fired. It will be much harder to kind of bring all of those symptoms back. You need to choose the right medication for the type of migraine you've experienced. We kind of choose different medications if you have a lot of nausea and vomiting. A pill that you have to swallow might not be the best idea because you might not absorb it. So there's oral disintegrating medications, there are nasal sprays and injections. Wake up migraines are notoriously hard to treat because there was no early period. You woke up and you were in the throes of it. And so those oftentimes need to be non-oral routes that work faster. And then menstrual migraine can be something that's more likely to come back, where in that period of time, either before the onset of menses, when your estrogen levels are kind of dropping, that you have a migraine one day and the next day and the next day and the day after that, and you treat it and then it comes back. And so you may need a longer acting medication in that situation. If you're using an acute med, one of the ways that we assess how well it works is how you define that it works. Does it works mean it reduces your pain, or it stops the pain from getting worse, or that you actually are pain-free in some certain amount of time? Does it help your associated symptom? Does it help the light sensitivity? Does it help the nausea? And what percentage of the time can you count on it to work? Is it a 50-50? I like take this and I hope that maybe it will work, or most of the time it works, but every once in a while for those ones like during my cycle or that I wake up with, it's not so great. And then the question is, does it last? Does the migraine return that day? Does it return the next day? What's the duration of the benefit that you experience? So these are the classes that we talk about for acute medication. Anti-inflammatories, which are NSAIDs, triptans, which are probably the oldest migraine, well, they're not the oldest, but probably the ones that you are most familiar with. It's a migraine specific medication. They work on serotonin receptors that are on the ends of neurons, and they prevent those neurons from getting activated. There's a class of medication. There's two new classes of medications. One is ditan, which is lasmiditan, which is like a triptan, except it some triptans, the way that they work, have some reasons that we don't use them for patients who have high blood pressure or who've had a heart attack or a stroke. And ditans kind of don't have that concern by the way that they work. And then gepants, which are the ones that are on the, if you are subject to any targeted ad campaigns as you're on social media, you may be seeing Ubrelvy and Nurtec. And then we have a new one called Zavegepant or Zavzapret. And those are medications that work on CGRP, which sounds like alphabet soup, but it's a neuropeptide that's released by the nerves activated during migraine that's involved in pain signaling. And then an old medication that we still use is in a class called Ergot, which is DHE. The problem with this medication is that it's not really that great in a pill. So it usually comes either in a nasal spray or an injection. I have asked to put an asterisk next to anything that had a non-oral formulation. So whether there was an injection or a nasal spray, just so you're aware that there are different ways that the medications are delivered.
Can you comment for a second
yeah,
on
yeah, go back. Sure.
Intranasal lidocaine for acute treatment? We've had some questions about this in our practice recently.
Yeah. So intranasal lidocaine has been around for eons. I think initially, so for cluster headache, the other type of headache that I talked about, they did intranasal cocaine at one point in time. I'm not making this up, but as an anesthetic. And then the idea is that behind your nose, there's a bundle of nerves, and it's called the sphenopalatine ganglion. And there is actually a procedure called a sphenopalatine ganglion block, or an SPG block, where you anesthetize that bundle of nerves. And so when you're doing intranasal lidocaine, what you're trying to do is, for lack of a better explanation, a poor man's SPG block. There's an in-office procedure where you can do an SPG block. You can do it with a Q-tip. You can do it with, they make specialized catheters, but then you can teach patients to use essentially just a syringe. The nasal sprays, like you think of a traditional nasal spray, if you think of like Flonase, they generally don't get there and stay there long enough to really provide good result. You have to lay your head over the side of the bed and then turn it to the side that if you have a unilateral headache, if you have a one-sided headache that you're trying to anesthetize, and then administer about 1 ml of fluid of the lidocaine, or oftentimes we use viscous lidocaine because it's thicker and it will stay there. I have a patient who tells me that this is my waterboarding technique for this. But you can anesthetize the SPG, and that can be helpful for migraine or for cluster headache. And the benefit of intranasal lidocaine is you can't get in trouble really with, like, you can swallow it. So you want to and it can get in the back of your throat, but you don't absorb very much of the lidocaine. So there's no concern if someone can't take any of these medications because they have other medications that interact or they have side effects. Intranasal lidocaine is relatively easy and safe to utilize. It's also dirt cheap. It is a little bit of as a physician, it's a little bit cumbersome to prescribe. But if you YouTube SPG block, you will find videos of how both physicians administer it and then how patients can do it themselves. I won't tell you I think it's awesome as an acute medication, but it is an option. And it's something that you can do frequently if you have high frequency and not really kind of get into trouble. So yeah, that
Thank
is
you.
intranasal lidocaine. So one of the things I was alluding to there is what we call medication overuse, or you might have heard it called rebound headache. So if you've been treated for migraine before and interacted with a physician, they may have counseled you that if you use some of your medications too frequently, they can increase the frequency that you experience migraine, and we call that medication overuse headache. The risk of medication overuse headache actually varies by what type of medication you're using. It's actually pretty uncommon if you're just using like ibuprofen or a single ingredient anti-inflammatory where it's just an NSAID. In medications that have caffeine, like Excedrin or other combination medications, or in triptans, the risk is that if you're using more than 10 days a month, you can increase the risk of developing medication overuse. And it's not like you take your 11th pill and all of a sudden the migraine just flies out. It's in patients, like if you are doing this month after month, if you have a crummy month and you used 12 triptans, that's likely fine. But if every month is terrible and you're using 12 or 15, that can be a double-edged sword where using the medication to make you feel better, actually the nerves are sensitized to fire more frequently. And so, I say it's a short-term problem or a short-term solution for a long-term problem. And then opioids, narcotics, and butalbital, which is one of the ingredients of a medication called Furoset or Furanol, are very likely to cause medication overuse. And oftentimes we avoid these medications. So in my clinic, we avoid these medications completely because of the risk. Both of these medications are actually habit forming. And there's a number of other concerns, but of the risk that it make the disease process worse and actually make the preventive medication less likely to work. Now, the newest class of meds that we talked about, gepants, don't seem to cause medication overuse headache, which is really cool. So they are acute medications that potentially, if you use them frequently, or some of them are dosed every other day or daily, actually reduce your migraine frequency, which is a totally novel concept for us, and great for us and great for patients, because as I'm sure many of you know, being stuck in this place where someone told you to use a medication early but not too frequently seems like, well, which is it? I'm not sure what to do, and I'm just trying to kind of get by. So who needs preventive? Preventive treatment is what we talk about when someone starts to experience frequent migraine. And frequent migraine obviously is kind of a nebulous term. We usually think about it in the range of 4 to 6 days per month or more, especially if your acute medication is not working very well and you have migraine-related disability where you're canceling plans, you're missing work, or you're overusing your acute medication. So if you're rationing your triptans, so say you get 9 or 12 from the pharmacy every month and you are waiting for when you know they can fill the refill because you're desperate, or you play the game of, is this migraine worth treating? I'm not sure it is. I think I can grin and bear it and take the over-the-counter Motrin that I know won't work, but that's fine. That's when we talk about, being on preventive. The other the consequence of using acute medication too frequently is just that it starts to tear up your stomach, and it can be hard on both your kidney and your liver. The medications that are used to treat migraine acutely, with the exception of gepants, aren't intended to take frequently, and they're not safe to do so. And then of course, it's all in the patient's kind of, this is what you live with. So you make a decision about, whether or not you can have 3 migraine and be like, I want to be on preventive. This is terrible. You can have, 8 migraines a month and say, my medication works awesome. It hasn't changed over the past 4 years or whatnot. I'm just going to keep with this. That's okay. So preventive migraine treatments fall in these categories. And I always have to caveat that it seems strange. We use these anti-seizure medications, antihypertensives, and antidepressants. Those are the categories of medication that we have used historically for years in migraine, not because these disease processes have anything to do with migraine, but because these medications work to decrease the frequency of nerve firing and decrease the activity of nerves in that occurs in migraine, and that's why we find them useful. Oftentimes we are using much lower doses than as they are intended for kind of their primary indication. There's also botulinum toxin, so Botox on a botulinum toxin A is used. It's specifically indicated in patients who have chronic migraine. So in clinical trials to date, although it's getting evaluated again, it hasn't shown to significantly reduce frequency of migraine in patients who have less than 15 days a month of headache as compared to placebo. The new medications that we have are CGRP or CGRP receptor monoclonal antibodies. And they're antibodies not because they have anything to do with kind of modulating your immune system. They just use the antibody to be a very specific way to bind to this molecule, CGRP, to block it from getting activated. Now, the benefit of monoclonal antibodies is that they have a very long half-life. The downside is that they're big molecules, so you have to give them as an injection. So these are subcutaneous injections that you administer once a month to reduce migraine frequency. And then there's one, the first one on my list here, eptinezumab, is actually administered IV. It's a quarterly infusion. And so these medications have been on them available for probably about 5 years now, and are really remarkable in that they are specific to migraine pathophysiology, so developed specifically for migraine. And they're very well tolerated. They don't have a lot of side effects, which has been kind of the rate limiting process for the oral medications we've had for years, is that they work really well, but a lot of people have side effects that make them not that awesome to take. And so if you substitute some new side effect for having migraine, you haven't gained very much. G-PANTs are the medications I was talking to you guys about for acute. They're also used for preventive. They also target the CGRP receptor, but these are pills. And so rimegepant, which the brand name of which is Nurtec, is dosed every other day. And then atogepant, which is Qulipta, is dosed daily. And those are also fairly well tolerated. Unfortunately, these two new classes of medications, although they are very well tolerated and specific to migraine disease, have not shown to be remarkably better in clinical trials than the medications that we had in terms of how well they work. But if I tell you that like the medications that we had worked really well, but no one took them because of side effects, then you would see that these are better. Now, oftentimes we can get around this, and I use the older medications very frequently, and we just make really specific choices about what dose to use and to titrate fairly slow. Now, you may be encouraged to hear there are some vitamins that have data for migraine. I put this pill box up here because I always joke, these are called nutraceuticals. So that's the word for these vitamins that have data to reduce migraine frequency, is that although it's a vitamin, you can't take it like a vitamin, which is like here, now, and again. You have to take it every day in order for it to be effective. So we use magnesium, and it can be what you can find over the counter at like CVS or Walgreens. It's magnesium oxide, and it's usually 250 milligrams to 500 twice daily, oftentimes taken with meals. The way you get rid of excess magnesium is in your stool, and so everyone has a propensity for how much magnesium is too much and you get diarrhea. And if you're tummy sensitive, then magnesium glycinate is a little bit better absorbed. Riboflavin, which is vitamin B2, which, fun fact, turns your urine fluorescent, and is way more B2 than you need in like a multivitamin. You are super supplementing, but it's used in like kind of the mitochondria or the energy part of the cell. And so that's the reason that we think that it's helpful. And then coenzyme Q10 is also helping mitochondria, and that's 300 milligrams daily. And that generally is well tolerated. But those all have data if taken daily to reduce migraine frequency. So sometimes if you're on the fence about whether or not you need a prescription medication, this is a good starting point. There are a couple plant extracts that have evidence. I don't love them. You have to oftentimes monitor liver function with using these medications, and they're generally taken off guidelines because of that. But those are butterbur and feverfew. So how do you choose a preventive? I gave you like a laundry list of all the options. And if I give you that in clinic, what do we choose? So the big drivers are how well it works and what we oftentimes think is best for you. And that's a combination of what you want and what I think might be appropriate in terms of other disease processes. Obviously, side effects play a big difference. Headache frequency, some medications have better data for high frequency, and so that we're more likely to choose that. We choose it based on, does this medication have weight gain? Does it cause weight loss? Can you take a medication every day? Can you self-inject? Are you allergic? And Dr. Cilenti is well aware of this concern. Will your insurance cover the medication? And so in general, for the newer medications that are available, most insurances have a requirement that you've tried 2 of the generic meds first and either demonstrated that they didn't work or that they had intolerable side effects. And then in general, the newer medications are covered, although oftentimes they have a preference of one of the newer medications over the other. So lots of my day-to-day job involves playing that game, which is funsies. What are our expectations for when we start a preventive? So it can take around 8 to 12 weeks to see a reduction in the frequency attacks, which is a long time, I know, but we're changing the likelihood for nerves to fire, which means that it has to do with like receptor expression and neurotransmitter release. And those things kind of aren't immediately taking place right after you've taken a medication. They are downstream effects as a result of how the medication affects the nerves. The goal is to experience fewer attacks that are shorter, less disabling, that your acute medications work better, and that you need them less often. Most of us are not pill people. We're not keen on the idea of needing another pill in my pill box, another medication that has a side effect profile that's expensive. I totally get it. There is data for other interventions to reduce migraine frequency. These are oftentimes actually not facilitated by a physician, more often a psychologist, not because we think anything about your mood is the driver for migraine. It's not the anxiety or depression, or it is not a neurotic woman that gets migraine. It's that cognitive behavioral therapy helps change our thought process involved in pain. So the part of your brain that lights up when you're experiencing a chronic pain like migraine that occurs again and again is actually the part of your brain that's more involved in emotion and memory. And it's the anticipation of pain that oftentimes becomes a driver. And so reframing how we think about migraine actually can change your experience, which is always kind of mind-blowing, but there is really good evidence that CBT reduces migraine related disability. Biofeedback involves a lot of the same principles, but with what I call like a physiologic carrot. So if you're doing mindfulness and meditation and you're focusing on your breath or your heart rate or your blood pressure, they oftentimes are using like a parameter where they're monitoring your heart rate, and with the concentration you can change these things and then also change your pain. There are neuromodulation devices. So these are devices that you actually typically wear on your head, although one of them you wear on your arm, that modulate the nerves. So there are 5 that are available for these. Now, the downside of these is neuromodulation devices are what's called FDA cleared, meaning that the level of evidence needed for the FDA to let them come to market is a little bit lower. Doesn't mean that they don't work, because they have, placebo-controlled trials that show they're effective, but it means that insurance won't cover them. So they are considered experimental by most insurance plans, and sometimes can be cost prohibitive. But some of them are like more reasonable, and we can talk about those in more detail if anyone has questions. Acupuncture, I get a lot of questions about acupuncture. Acupuncture has data, even some sham-controlled acupuncture, to reduce certainly migraine acutely, although that's not very useful. Like I have a migraine, I need to go to acupuncture right now, but also going regularly. I just kind of caveat this for patients that you have to commit to doing acupuncture on a regular basis for usually a 6 to 8 week period of time to kind of evaluate the efficacy. Some patients are able to then space out and decrease the frequency of acupuncture. Some patients are not. And so at some point in time, it is like a time and financial commitment. And then I talked about the nutraceuticals. All right, so my prescription for everyone who joined us today is actually advocacy. because one of the reasons that migraine's been around for eons, and I was in practice for 10 years before I had any new medications. The 1990s were when triptans like Imitrex first were released. And then it's just been in the past 5 years that we've had these new medications come out. And it is very much a disease of women that doesn't get the recognition or the funding that it deserves. And I think part of that has to do with the fact that we all just suck it up and soldier on through our days and don't talk about how awful it is and let someone else tell our story. So if you experience migraine, I would encourage you to be brave and talk about it with people at work and with your family, and kind of explain that migraine is not just a bad headache. It's not just something that happens when you're stressed out or when you didn't drink enough water. It's a neurologic disease, and it is super disabling. And I only think that by talking about it more and bringing more awareness, can we get recognition from things like NIH, and from researchers to have better medications to kind of move the needle forward and make our patients more functional. There is, really remarkable communities of patients with migraine. The American Migraine Foundation has a Move Against Migraine campaign, and then Miles for Migraine, and we have a Miles for Migraine race here in DC, is a patient advocacy group. And so I have information here. If you're interested in joining us in September, we have a Walk, One, Relax, which actually supports my disclosure here is the Miles for Migraine race does support the fellowship program. So we have 2 headache fellows that are neurologists who are doing a year of certification in headache medicine. There are only 700 headache specialists in the country, and there are 47 million, and that number is probably dated, people who have migraine. So there are estimates that said that if I see patients 24/7, 365, I would still have a 3-year wait list. And that's like, accounting for all of the patients and providers who are headache specialists. So we clearly need more research and information in this area. And MedStar, we're doing it 2 at a time. I'm trying to clone myself. Miles for Migraine, if you go to their website, they offer a lot of really cool things, including advocacy training for migraine. They have a mindfulness series. They have support and community groups, oftentimes I think they're most often virtual. And they do work with pediatric migraine, including talks for teens, which is awesome. And then we will have Q&A because I left myself, all of 3 minutes. But all of the resources here, if I didn't answer your questions, American Migraine Foundation has amazing resources on migraine. All right, I will stop my share and we will take questions.
Well, thank you. And I will say to the group that Dr. Dougherty had one condition for agreeing to come on an evening and give this presentation to our patients at NVFP. And her condition was that she also got to spend an hour with all of the providers at NVFP, educating us more about how to manage migraines in primary care, so that she can at least get some break from those, 3 years of seeing patients 24/7, 365.
No, I am always really appreciative for primary care. That's the first person who hears about migraine. It's not me. The first person is who, and so I would encourage everyone to, if you're here, make a dedicated visit to move migraine up to your problem list. No, it's not a deadly disease process, but Lord, does it affect your every day-to-day activity. So I think it's really important.
So we really appreciate her expertise, but I want to spend some time on questions. So I think one question was about sort of genetic overlap between different types of headaches. So if a parent has cluster headaches, is a child more likely to experience migraines? And how do parents who have migraines sort of cope with, oh no, now my kid has them too?
It's super hard. I will tell you that I often joke that I feel like family practice because migraines are genetic. So I see mothers and daughters and sisters because it certainly runs in families. And having other headache disorders does increase your likelihood of having kind of any headache disorder. Cluster headache is so infrequent that I don't think there's actually good literature out there on cluster affecting migraine frequency, but the dysfunction happens in the same place, the hypothalamus and the trigeminal nervous system. So absolutely, there's overlap in terms of like shared genetics. In terms of having children, it's really like you having migraine and then having a child who has migraine, that you are such an amazing resource to teach them early how to recognize the signs and symptoms and how to help themselves. And for kids, a lot of the interventions that occur with migraine kind of gets at like preaching the regularity. I joke I never have to tell like a middle-aged mom that she needs to wake up and go to bed at the same time or live her life on a schedule. She's like, yeah, I got all that. I figured that out a long time ago. It's my Georgetown undergrads who have crazy class schedules and stay up late and then sleep in and then go on spring break. And you as a parent have the ability to start to kind of create those healthy life habits that say, you have to go to bed, you have to turn off the screen, you got to drink water, you got to eat meals, you got to keep all of those things regular, because those are the things that kind of make your brain work best and not get sidelined by migraine.
There was a question, we talked a little bit about, that consistency, but any evidence about weather triggers for migraines?
So weather gets at the same idea as change, so that migraine brains don't like change. There is not good evidence that weather, like they have actually diary studies where they tracked barometric pressure and patients' migraine diaries, and were not able to find like a correlational relationship that barometric shifts were associated with increased migraine frequency. Despite that, I will tell you every patient in my clinic will tell you that they are prone to migraine with weather fluctuations. There is evidence that like flying at altitude, going to elevation. And so I think there is some logic behind that. Unfortunately, I can't change the weather, and there's not any good evidence that anyone, like I often get asked, like, what's the best medication for patients who have weather associated migraine? It still gets back to the idea of the genetic dysfunction, that we don't think that those environmental factors result in any unique pathway. It's just the sensitivity of the system, and that if you're on an effective preventive, you are more resilient for fluctuations in your environment, including weather.
And the other thing I will say is that I think a lot of people who have migraines often think they have sinus headaches first. And so if you or someone you love is complaining of very frequent sinus headaches,
You have
perhaps they should
migraine.
talk to their doctors about migraines.
Yes, sinus headaches are like, if you ask headache specialists, we in general don't think sinus headaches are really even like an accurate diagnosis for much of anyone. If you have a raging, like you have a fever and purulent discharge, and you have like an acute sinus infection, I will allow a sinus headache, like yes. And that may even give you a migraine, having all of that in there. But if on a regular basis you're experiencing pain that is like in your cheek or around your eye, and you have eye watering and nose running, and you take a decongestant and feel better, that's still likely migraine. Autonomic symptoms are really common during migraine, and they have eye watering and nose running because of the trigeminal nerve activation. And there is some evidence that even decongestants can essentially be helpful for like an acute treatment for migraine. We don't recommend it just because they can be habit forming and cause more problems than they solve. But your logical kind of deduction when you experience that and then take a Sudafed and it makes it better is like, oh, well, it must have been a sinus headache. If you felt a little nauseous or the light was bothering you, yeah, you probably need to be talking about migraine.
I have a couple more questions if you have a few minutes, though we are approaching 8 o'clock. We did have one question about treatment refractory migraines and using naltrexone.
There is not any like clinical trial that has evaluated like low dose naltrexone. It has anti-inflammatory properties, but it hasn't been, to my knowledge, shown to be effective in migraine. I don't have a lot of clinical experience. I don't have a reason to counsel someone against it if you've tried other things. I don't think there's any evidence that it would worsen migraine frequency. Oftentimes when we get to the end of the rope, when we don't have a lot of data, we are trying things that we think just based on mechanism of action would be helpful. And I would say low dose naltrexone would kind of fall in that category.
Great. And then can you talk a little bit about the different neuromodulation devices? And I think we'll probably wrap things up after that, but I do think they are really interesting. So I would love
Yeah.
to hear your thoughts on
Yeah.
those. One of my patients.
So some of the devices are essentially based on the concept of TENS unit. So if you've ever been to physical therapy and they've used the TENS unit, it's the same concept. It was the gate theory of pain, which is an electrical stimulus coming in to activate those nerves, actually serves as an interrupter for ascending pain. And so there's like a little gatekeeper neuron in the spinal cord that's like, oh, electric's coming in, stop the pain from we got to go this way. And so the TENS unit kind of sits and activates these nerves, which is your supraorbital and your supratrochlear nerve in your eyebrow. And then that's the Cefaly device, Cefaly. And then in the back, there's one that's called Relivion that does both the occipital nerve and the trigeminal nerve branches in the front. And so those have data both to be worn when you have a migraine, so to be effective acutely, and also that if you wear them regularly, they reduce migraine frequency. Cefaly is actually over the counter. You can purchase it without a prescription. It is expensive. It's probably in the order of like $400, but you own it and then can use it as much as you'd like. The other devices are Nerivio, which is a stimulator that goes on your arm, and actually having this buzzing on your arm that's controlled by an app on your phone activates the part of your brain that inhibits pain. And so wearing that for an hour has data to reduce acute migraine, and then wearing it every other day has data to reduce migraine frequency as a preventive. There is a device called a TMS device that you can apply to the back of your head at the onset of aura. Unfortunately, it's ridiculously expensive. I think you rent it for like $300 a month. So we very rarely use those because they end up being like a mortgage payment. And then there's a vagal nerve stimulator that you can use applied to your neck that stimulates the vagus nerve, which is also unfortunately very expensive, but has data for both cluster and migraine. I think that's all of them. But like I said, American Migraine Foundation definitely has in their resource library information about neuromodulation devices and the differences, because they all work differently. Although we talk about them as a category, you can't really compare and contrast them.
I think they're so interesting, and I think a good option for people who are not pill people to look into. Particularly if you think about, the co-pays that add up over months and months and months of taking a preventative, you can kind of get to where Cefaly is maybe not so cost prohibitive anymore.
Absolutely. And the Nerivio devices also, like they essentially did the pricing to be similar to essentially a copay. And so like the Nerivio device that you wear on your arm is also reasonable. So those are the two that we probably use most commonly in clinic, just because you can afford them. So.
Well, I think we've hit most of the questions, and several messages that said thank you and come back and talk about cluster headaches. And man, I wish I would have had this presentation years ago. So thanks to everyone who has joined. This will be available on the website once it's processed. So if you have friends or family with migraines, please send them to the recording to listen and learn. And thank you so much to Dr. Dougherty for helping us at NVFP be better at managing migraines for our own patients, many of whom are here tonight, and for just helping us to understand better this super common disease and how treatable it can be and how much room for improvement there is in migraine care.
Thanks so much, Dr. Cilenti. I really appreciate it. Have a good night, everyone.
Thank you.
Bye-bye.
Bye.